Hello, this is going to be a brief presentation on inpatient diabetes management. First, most important thing is to talk about the actual diagnosis of diabetes. This is done by achieving the one of four criteria. First is a fasting blood glucose greater than 126. Second is an oral glucose tolerance test greater than 200. This is really only done in pregnant or cystic fibrosis patients. Third is a glucose greater than 200 with symptoms of hyperglycemia. And finally, an A1C greater than 6.5%. If a patient meets any of these criteria, they have the diagnosis of diabetes. If there is any question, you can always repeat the test. On the inpatient setting, there's really three goals for management of blood sugar. First and most importantly is avoiding hypoglycemia. This is deemed glucose of less than 80. This can lead to acute syncope, lightheadedness, issues that cause more acute issues than the long-term side effects of high glucose. Second, we try to have a blood sugar target between 140 to 180. This is based on ADA guidelines and previous trials that showed a more aggressive target blood sugar, meaning a lower target blood sugar, actually led to more deaths in the ICU and in severe sepsis settings. So we have a little bit more of a conservative target with a goal of 140 to 180. Third component is this idea that basal plus bolus is actually better than just sliding scale alone. We'll talk a little bit about this in a second. But the idea that using a combination of insulin strategies is the best way shown by the evidence to keep patients safe. There are three major types of insulin that I would say on an inpatient setting you need to be aware of. First is basal, which is a long-acting insulin. These are things like Lantus, Basaglar, and Toujeo, also known as Glargine or Detramer. The second is bolus. These are short-acting insulins. These are Novolog, Humalog are the brands, with Aspart and Lispro being the generic names. And finally, 70-30, less common, but can be seen where you're essentially using it as an intermediate with a bolus level of insulin. When a patient's admitted to the hospital, their diabetes may not be the number one issue, but it's something that has to be controlled. Some patients will have been on insulin in the past, and others will not have insulin or may not be taking any medicines. They may just be on orals or nothing. These are 5 steps of really managing the inpatient diabetes. We're going to talk about them more individually, but first is stopping oral medicines. Second is determining a sliding scale or corrective insulin level. Third is considering whether to continue a long-acting insulin. Fourth is calculating their total daily insulin to better your regimen. And 5 is just planning for dispo. First is stopping oral diabetic medications. This is because of side effects that can occur. Metformin has a risk of lactic acidosis in the acutely ill and in acute kidney injury. A lot of patients are sick. This increases the risk of metformin toxicity. Similarly, sulfonylureas have an associated increased risk of hypoglycemia. Other oral diabetic medications don't have a lot of evidence for use as an inpatient, so we hold them as well. Second is determining what level of sliding scale insulin you're going to use. Now, sliding scale is essentially correcting for high blood sugar. So if a patient has a high blood sugar, they're going to receive a specific sliding scale amount of insulin to correct for that blood sugar. In most hospitals, there are 3 levels of sliding scale: low, medium, and high. These are determined by the pre-hospital total daily insulin levels. So these are for patients that are on insulin in the outside. You can see that the amount of insulin is what determines whether low, medium, or high. And then finally, in sliding scale insulin, we have to check the glucose to see what we're going to correct. If a patient is NPO, then they need glucose checks every 4 hours. If they are eating, then they get glucose check with every meal. If a patient is on long-acting insulin at home, you'll have to decide if you want to continue that medication. If you do continue that medication, it's usually best to reduce the total amount. Just because the patient's sick, you don't want to drop them too low, and their diet may change while they're in the hospital. It is important to be careful when restarting a home medicine if they are truly not taking the medicine at home, if they're non-compliant. Giving them an extra dose of insulin, meaning if they are on 100 units at home but never actually taking it, giving them 100 units in the hospital can really bottle them out. The other thing you can consider is actually just using a weight-based approach where you do 0.4 units per kilogram, and that can give you a decent baseline level of the long-acting insulin that a patient would need. Now, after the patient is admitted to the hospital, each day will have to continue to figure out exactly what insulin levels they need. The way to do this is to calculate the total daily insulin levels to determine a basal bolus regimen. So to calculate the total daily insulin, it's basically any level of insulin counts as the same unit. So if one day a patient is on sliding scale only and receives 20 units of insulin, their total daily insulin will be 20 units. Now, let's say a patient is on 9 units of Lantus at home. They come in and are also getting 3 units of Lantus with breakfast, lunch, and dinner. And we put them on sliding scale, so they get another 2 units total for corrective glucose. You add all of that up, 9 plus 9 plus 2. You also get 20 units of total daily insulin. So both of these are equivalent. Once you have a total daily insulin, you have to determine how you want to break that up to be administered to the patient. The most common breakdown is giving a long-acting basal insulin, which is going to be 40 to 50% of your total daily insulin, while your nutritional insulin is going to be 50 to 60%. If you do 60%, often you can then split it up into 3 doses, breakfast, lunch, and dinner, which is 20%, 20%, 20%, with the other 50% being the basal. So if we have a patient with these 20 daily units, if we do a 50-50 breakdown, we would give 10 units of Lantus, that's 10 units of the basal insulin, plus a total of 10 split out over nutritional insulin. That can be 3 units with breakfast, 3 with lunch, 4 with dinner. Or if we want to split it into a 40-60, we can do 8 units of Lantus with 4 units in breakfast, lunch, and dinner of nutritional aspart, and then also continuing the sliding scale insulin in case they go over. Of note, rounding is very much encouraged and frequently used in these calculations. Finally, we reassess. When the patient's on basal insulin and nutritional insulin, if the sugars are still elevated and are requiring sliding scale, you got to recalculate the total daily insulin, readjust the basal bolus insulin regimen, and go up accordingly to make sure that their sugars are within that target 140 to 180. 5 is the dispo planning. So this is something that when patients are nearing discharge, you really have to start asking yourself. One is, if a patient is on oral medicines, are you going to restart the medicines? Usually the answer is yes. Second, is this patient going to need insulin for discharge? If someone's diabetes are way out of control, they might be initiated on insulin during an inpatient admission, which is going to require some education and making sure that they're able to get the medicine. Finally, if they are going home with insulin, you'll have to figure out what regimen. There's a few to choose from. Some patients do well on just a long-acting basal insulin alone, like Lantus. Some use a basal insulin and then nutritional with meals, a set number of nutritional. Others do basal with carb counting, where they will adjust how much nutritional insulin they get based on their meal. And then less commonly, but something that can be done, is using 70-30, which is a combination of insulin NPH, or intermediate insulin, and aspart, a short-acting insulin, where you can use that twice daily. Sometimes this is cheaper for patients, but otherwise is not frequently used. Finally, a brief note on diabetes ketoacidosis. Diabetic ketoacidosis is outside the scope of this lecture a little bit, but something worth mentioning when you're talking about blood sugars. For a diagnosis of DKA, you need the D, the K, and the A, meaning you need diabetes, which is elevated glucose or known diabetes. 2, the ketones. You need a generation of ketones, which we often measure as ketonuria, or ketones in the urine. And then 3 is the acidosis. That is a pH of less than 7.3 or a bicarb of less than 18. Without all 3 of these criteria, the patient is not in DKA. If a patient is in DKA, they most importantly need fluids to help stay hydrated. Second, they need an insulin drip. This often requires a higher level of care than a floor patient. This requires intermediate or ICU care. And that insulin drip is titrated to the ketones or ketoacidosis, not to the glucose, but there is a very strict algorithm that you're able to follow. They also require frequent lab monitoring, which is also why it's important to have them at a higher level of care so that you can get frequent lab checks to see how they're doing. This is every 1 to 2 hours, depending on how bad their DKA is. And that's it. If you have any questions, please shoot an email at jburke7@jhmi.edu. Happy to get any feedback of how these can be better, if they're helpful, if they're not helpful, and what other questions come up. Or if you find any mistakes or errors, please let me know and we can correct them. Thank you.